Hi, this is Roger. I'm back, and I want to talk this episode about the surgery that I had. So, as I said, I had what they called a borderline resectable tumor in my pancreas. And borderline means, yes, the resectable means they can remove it surgically, and borderline is that, well, we'll have to kind of wait until we get in to take a look at it to know for sure, because there was more than 180-degree encasement of an artery. As it turns out, I was lucky enough that it was able to be surgically removed. Now, I didn't have much choice in the chemo, right? And the doctor just said, this is what you're going to do. I mean, I could have said no to the whole thing, but it wasn't like I was picking which chemo and how much dose, right? That's certainly not something I could do. That's what the oncologists do. However, when it came to surgery, that was up to me as to when to have, not only when to have that surgery, but what type of surgery to have. So I had to do a lot of research, and I had to get second opinions. And I talked to a lot of surgeons, and I got different opinions from different surgeons. Should we do 2 months of chemo and then surgery, and then 4 more months of chemo? Some people said that. Oh, no, do 6 months of chemo and then surgery, because you won't have enough strength to do chemo after surgery. I got that answer from one very respected oncologist. Do surgery immediately to keep that tumor from growing to a point where it can't be removed, and do your chemo later. I got that opinion. So it was all over the place. But for the most part, there were two camps. 2 months chemo, surgery, then 4 months chemo. And the second camp was 4 months chemo, surgery, 2 months chemo. And since I'm a lawyer, I do what I do best. I compromised, and I decided to do 3 months of chemo, and then surgery, and then 3 more months of chemo. And I don't know, I think that's the right call. So we did the surgery, and I'm getting CT scans all the way. So that's decision number one. Decision number two, what type of surgery, right? It's not that simple, and it came down to me between two types. One is called a distal pancreatomy, which is pretty much the standard in this country. The other is called a RAMPS procedure. The R stands for radical, so it gives you an idea of what it's like. And again, I found very respected, good surgeons from top institutions that had very strong opinions on this that were exactly the opposite. And I couldn't really get a consensus. I mean, everybody I talked to had a strong opinion why one was better than the other, but I couldn't really, it was hard for me to understand which was. But again, I had to make that decision, because whatever surgeon I picked was going to use their procedure. And I spent a lot of time talking to surgeons saying, tell me again, exactly what are you going to do? Show me a picture. What if this happens? What if that happens? Etc. So I went through it, and the RAMPS, the doctor who recommended the RAMPS told me that he would improve my chances by 50%. He would double my chances, is what I mean by that. The 5-year survival rate with RAMPS is 42%. Without it, it's about 25%, so it's almost double. Nevertheless, at the end of the day, I did not choose that procedure for various reasons. I went with the distal pancreatomy process. And that brings me to the third point. I had to choose a surgeon. And all these guys are top-notch. All these guys know what they're doing. But I probably could not have made a bad decision on a surgeon, but I chose the one that I really had the sense was the most personally invested and would be the most offended if the surgery failed. So that's who I chose, the guy that I thought was going to work the hardest to save my life, because who knows what they're going to find once they actually open you up. Now, I had 3 months of chemo before the surgery. They did a CT scan, and the surgeon was very excited about that. First of all, he's happy I lost 30 pounds, because that makes it easier for the surgeon. But more so, he was happy because the tumor actually shrunk. And he said, look, the chemo worked. The tumor shrunk. He says, you're winning. You're winning in this. And I was winning until I wasn't. And when I wasn't was after the surgery. And I remember waking up, and I had it in my mind, I'm going to look at the clock as soon as I wake up, because that'll tell me whether they were able to do a surgery and whether it went the way they thought, because I know how long it should take. It took a little longer than it should have because they ran into some stuff, but they took care of it. The problem, however, came later with what they call the path report, the pathology report. So they take that tumor, they freeze it, they slice it. And by the way, here's another pro tip for you. You really need to make sure that the institution, the surgeons understand that you want to preserve that tumor tissue for analysis, because that's going to be super important in determining what you do next. So in my case, they take the tumor, they slice it, they freeze it, they analyze it. And the path report came back as bad as it gets. In fact, it said all that chemo that you did, that 3 months of pain and suffering, didn't do a bit of good. The cancer laughed at it. And that happens with pancreatic cancer. First of all, it forms, pancreatic cancers, unlike other cancers, it forms somewhat of a fibrous shell around it that keeps the chemo out. And there's fewer cancer cells in the tumor than other types of cancers. So it's a harder thing to treat. And then thirdly, because of it's usually a KRAS mutation, that's just one more, mutation that's harder to kill. So what happens that sometimes and very often in pancreatic cancer, I understand, that you'll find no treatment effect, but the doctors all thought there would be because the tumor shrunk. So now I got to talk to the oncologist. What are we going to do now? And I remember I talked to my main oncologist, and the first thing he said is, he looked at the pathology report and he said, gee, that's disappointing. And, disappointing is when the 49ers lose the Super Bowl. Disappointing is when NVIDIA drops, in the market. And you're going to die of cancer. That's disappointing. Because if the chemo didn't work, that's pretty bad. I mean, that means, again, poor prognosis. It's, in big black bold letters on my pathology report. And I said, well, now what do we do? And he says, well, we're going to take a blood test through a company called Natera, has a Signatera test. We're going to look for circulating tumor DNA in your blood, and we're just going to get a baseline and see how bad it is, which is kind of like saying, this thing's already probably micrometastasized. Let's see how bad it is. All right, so that's pretty pessimistic. So I went to my second opinion guy. He was even worse. He looked at that path report, and he said, oh, we need to get you on these targeted therapies. And I said, well, I've been reading about those targeted therapies you want me to take, and they're pretty toxic. In fact, they're worse than the chemo. And in fact, if I don't die of the cancer, I'll die of the targeted therapy. And he said, don't worry, he said, because you're definitely going to die of cancer before you die of anything else. Okay, so that was his opinion. I did go to a third person who echoed that. He says, just a matter of time, it's going to come back. Probably 3 months, maybe 6. Sometimes it takes a year, 18 months tops. Well, that was 2 years ago, okay? It hasn't come back yet, right? It's been more than 18 months ago, and it hasn't come back. Now, what they were really saying, and what I heard from this, is not so much that this cancer is absolutely going to come back and you're going to die. What I heard is that this cancer is going to come back if you don't do anything else. That's what I heard. And I also heard this is what standard of care has to offer you, and that's all. And that's when I really started going beyond standard of care. And standard of care is it's a phrase you're going to hear a lot, and that is basically what U.S. doctors are allowed to do in this country, what the FDA approves and what insurance will cover primarily. That's kind of a good way of thinking about it. And it's also, I guess, what doctors would generally do. I guess the proverbial reasonable doctor would do in that case. And doctors, most of them, especially at large institutions, are very reluctant to go beyond that. Now, if you get a targeted off-label drug, that's a drug or a repurposed drug that's meant for some other disease that they apply to you, that goes a little beyond that. If you go to stuff that's not FDA approved, that goes beyond standard of care. So important to keep in mind. Okay, so there I am. So they say the chemo didn't work and we need to switch chemo. But my surgeon called me up. I was out on my mountain bike when he called, and I thought, oh man, because he told me not to do that. I said, how did he know? But that wasn't why he called. It wasn't to yell at me. It was to tell me, he said, look, he said, I saw that tumor, I took it out, I watched it shrink. I think the chemo did work. Don't switch. Stay on the 5FU. My oncologist said, I don't know, pathology report says it didn't work. I'm going to take it to the tumor board and we're going to figure this out. And my approach was, well, let me ask you a question, doc. I said, how long does chemo usually work? Because I've heard that it stops working after a while. And he says, yeah, it does stop working, say around 4 months, on average, I'd say. And I say, okay, well, I took it for 3 months. Isn't it possible that it worked for a little while, shrunk the tumor, then stopped working, and the tumor grew again? Because it looked to me like it moved. I mean, I'm not supposed to be reading scans, but that was kind of how it looked to me. And he said, yeah, that's entirely possible. And I said, well, it seemed logical to me, and I don't know if I get a vote on your tumor board, but if I get a vote, I think we ought to switch. And he said, yeah, okay, we'll let you know. The way they let me know is when I showed up at chemo the next time, and I looked at the bag, and it said gemcitabine on it. So they used a different type of chemo. So the surgeon lost that argument. Somebody else on the tumor board won that argument, and I got 3 months of a different type of chemo. Now, that had a whole nother set of side effects that I did not have from the first. One of which was neuropathy, which in my toes and in my fingernails that I still have today. And I may have forever, but I don't think so. It's not as bad as it was a year, 2 years ago. So we'll see. But then everything else, itching, insomnia, pain, etc., nausea. But anyway, I did 3 months of that. I lost my hair on that second chemo. My blood got really thin, so I would get nosebleeds for no reason. It was... Everyone says it's milder than the 5FU. For me, it was worse. So I guess everybody's different. Now, backing up, I want to talk a little bit about the surgery. The surgery itself, I was able to have, they didn't have to actually cut me open. They did it laparoscopically, I believe they call that, where it's really just a machine. They made 4 small incisions. So you heal much faster. And it's much milder, but still, when you come out of it, there's going to be a lot of pain. Now, the first thing that I was worried about was the anesthesia. I've heard about Joan Rivers. I know what happened to her, and I've never been under before. I've never had this before. I mean, any surgeries, even when they put my port in, I had them do local because I don't want to be under for anything. There's never been a procedure where I was under, so this is going to be my first time. So I was really nervous about it, and I spent a lot of time really interrogating the anesthesiologist about what are you going to do if this happens? What if that happens? And I said, I want to make sure you understand, tell me again, what's my resting heart rate? I don't want you to overreact and give me a bunch of epinephrine or anything like that. So I was probably way too nervous, and I'm sure I drove them crazy, but at least they made me feel like they really knew what they were doing, and that made me feel better. The other thing I did is I went through most of this process alone, but this is the first time I was going to be totally unconscious now and unable to make decisions. And I really wanted someone to be there to make sure that everything went well, who was really interested in my survival. And so I thought to myself, who's the one person in this world that I would want in that room with me? And that turned out to be my sister. And I flew her out here from North Dakota. And I said, look, your job is just to keep me alive, make sure the nurses know where I am and what's going on, and don't forget about me. Now, I know that's probably all a little unreasonable, but just keep in mind, statistically, 250,000 people a year die in this country from what we could call physician error, okay? And I know that's broadly defined, but I'm not one to take a lot of chances. So I flew her out here. She sat there with me, outside in a waiting room during the surgery. She sat with me in my recovery room the whole time. In retrospect, I wish I hadn't done that because first of all, didn't need to. I had excellent care. All the things I was worried about might happen did not happen. And secondly, I feel a little bad about the fact that I had to put her through watching me recover, because statistically, the other thing I know is that people recovering from surgery, the more opioids you take, the worse your survival prospects, the higher the likelihood of recurrence. So I made it clear, I want no opioids. However, they can't give you NSAIDs. That's the other type of painkiller because that causes your blood to thin. If you just have surgery, you don't want thin blood, right? So that leaves me with nothing, really, maybe a Tylenol. That was a problem because, first of all, I had to fight with the nurses to get them to not give me that treatment. They snuck it into my IV bag the first day while I was sleeping. They didn't make that mistake again. And then the second problem is that means I was in a lot of abdominal pain for a couple of days. So my sister had to sit there, while I lied on the bed and moaned. But as painful as it was, I'm glad I did that. And I don't know if that's cause or correlation, but I'm not taking any chances. So no opioids for me. But fortunately, like I say, I had the laparoscopic, so it wasn't that bad. It would have been a different story if they'd had to actually open me up. And I was out of the hospital in 3-4 days, and then back on the trail. I had to start out walking, but eventually got back into a fairly normal routine. So that was my surgery. I hope you'll tune in for the next one when I'll tell you a little bit about what happens after surgery.